Hi, everyone. Welcome to our Building Bridges to the Community lecture series from Northwell. Today, we are lucky to be joined by Dr. Jamie Hirsch. Dr. Hirsch is one of my close colleagues. We work together with him all the time on initiatives. He is an associate professor of medicine in the Division of Kidney Disease and Hypertension at the Zucker School of Medicine. He's also our assistant VP for clinical digital solutions, which means he can help us with all kinds of computer technical stuff. And I kind of consider him to be a preventive nephrologist. It's a term that I've sort of coined because he's just really involved in a lot of preventive initiatives that have to do with all of our fields: cardiology, endocrinology, nephrology, kidney disease, et cetera. And we've been working together. And tonight he's going to be walking us through hypertension. Hypertension is one of the leading causes of cardiovascular disease, and it's so important to target this. So he is going to take us through the ABCDs of hypertension. So Jamie, welcome. We're very excited to hear your talk.
Thank you so much, and thank you for inviting me and having me tonight. I appreciate being nominated to be a preventive nephrologist. We're starting a new field here. So let me just share my slides real quick, and we'll get started. Let's see. Okay, I'm going to assume that you can see my slides unless I hear otherwise. The slides hopefully will just take up part of the talk tonight, and we'll have a chance to take some questions and have some discussion. But I really wanted to kind of at least start from, with the basics for everyone, so we're all on the same page, and that we all kind of understand, why we talk about high blood pressure so much, so that we understand why it's so important, the numbers that we're targeting, what it all means, how we check our blood pressure, how we manage our blood pressure, and then we can kind of delve into some of the details. And I was forewarned that this is a crowd that likes to get into the weeds of the information and the data to understand really why we make the recommendations that we do. So we're going to bring in some of the studies that really support a lot of the stuff that we talk about. So for starters, I'm going to talk about blood pressure prevalence, blood pressure control, and the importance of blood pressure control. Talk about some of the guidelines, the targets that we're measuring, and the importance of proper measurement, which is a really big focus of some of the work that I do. We'll talk about the treatment for high blood pressure. That includes both diet and lifestyle modifications, as well as medications. And then kind of we'll wrap up with talking about practically, now with all that information, I have high blood pressure, what should I do? So first off, you have to realize that high blood pressure is extremely prevalent amongst both men and women. Early on, people are younger, it's much more prevalent in men, but women do catch up as they get older. And by the time people get into their 50s, 60s, and 70s, a majority of people have high blood pressure. On the one hand, it's a little bit part of aging. Your blood vessels get a little bit stiffer. On the other hand, a lot of it has to do with just a lifetime of different life stressors, and lifestyle things that kind of accrue. There's genetic, reasons why people develop high blood pressure, but it is really, really common. So if you have high blood pressure, don't feel bad. It's, sometimes it just kind of comes with the territory, but it is something that we do want to take seriously, despite how common it is. We also know at the same time that in the United States, blood pressure control is getting worse. This data only goes up, if you've noticed, to 2017, 2018. This is kind of a year-by-year look at the proportion of people who have blood pressure under control. And we barely ever got over 50%, and that was about a decade ago. This data are old, and the COVID years actually made blood pressure control even harder. So I think we're doing actually even worse. And so there's a tremendous area of opportunity to be able to actually control people's blood pressure. And that's great and really important both for an individual, for you, for me, for our own health and well-being, but also thinking about a population. How do we make sure that our population, the people around us, our communities really are living long, healthy lives free from heart disease and other complications of high blood pressure. And the reason that we care about high blood pressure, and this is something I really emphasize with a lot of the patients that I see, is that I don't care about a number, right? Like your blood pressure is 110, it's 120, it's 150, it's 180. That number alone is not really why we care about this. It's really because that number correlates with increased risk of complications throughout your body, from stroke to heart attacks to kidney disease to blood vessel damage, and to heart failure, early death, things like that. So high blood pressure, those numbers that we talk about, that top number, that systolic number, that bottom number, that diastolic number, if those numbers are higher, it increases your risk of having these things. I say, there's no guarantees in life, right? I'm sure we all know people that take very poor care of their health. They may drink, they may smoke, they may have high blood pressure, don't take their medication, and live to be 100 and somehow manage to get through. And there are people who do everything right and have complications and diseases early on in life. So I can't guarantee anything. Nobody can. But we do know that controlling our blood pressure will lower the chances of these things happening. It will put us in the best possible position to avoid heart attacks, to avoid kidney failure, to avoid strokes, to avoid all of those things that can be debilitating, that can impact our quality of life as well as our length of life. And when we talk about blood pressure, and I alluded to this already, we're talking about these numbers, right? You get a blood pressure, somebody slaps a cup on you, right? They get these numbers, they give you a top number, they give you a bottom number, and then you're like, well, what am I supposed to do with that? So these are, roughly speaking, the ranges of what we would consider to be normal and elevated blood pressure. So normal blood pressure typically is considered to be less than 120 on the top, which is systolic, and less than 80 on the bottom, which is diastolic. Slightly elevated blood pressure is just a little bit higher, 120 to 129. Once you're above 130, you already meet the definition of hypertension or high blood pressure, and that's on the top number, systolic of over 130. If your bottom number is over 80, then you also have hypertension. And it's not both, it's either or. So the bottom number could be high or the top number could be high. And that would meet the criteria or the definition for high blood pressure. Now, many of you might recall, if you've been around long enough, you know that there was a time when 150 was considered to be normal. And then for a long time, 140 was considered to be normal. And now you're hearing, oh, well, it's got to be less than, it's got to be even lower. And, you can, when I first learned this, I kind of rolled my eyes and said, we're just trying to make everyone diseased, pushing that number down so we can, cast a wider net to have high blood pressure across the nation. And the fact is that that's the cynical take on it. But the reality is that we're gathering more data and we're learning more and more about what is the optimal blood pressure for optimal health. And that's really why I want to focus on the studies. This was a major study that came out. It's a little bit old now. It's back from 2015, but this is one of the biggest, most important studies in blood pressure control in the last couple of decades. And it really solidified the importance of intensive blood pressure control. It was a study of about over 9,000 people, and they randomized people to more intensive blood pressure control, trying to get closer to 120 versus kind of the typical less than 140, which is the traditional kind of target. And if you see here, I just want to kind of show you two outcome boxes here. This is the primary outcome, and look at the orange line versus the blue line there. You'll notice the higher this line, the more outcomes, the more events occurred. And events in this case mean heart attacks, heart disease, strokes, heart failure, death. And you'll see that the group that got more intensive treatment of their blood pressure over the course of 5 years had fewer events. In other words, they were healthier. Similarly, taking just death from any cause whatsoever. If you look here at the end of 5 years, the group that had the intensive treatment, trying to target a blood pressure closer to 120 versus trying to target a blood pressure of closer to 140, you'll see the one who was much more aggressive on the treatment, they tended to do better overall as a group. I'll reiterate what I said earlier. There's no guarantees. Obviously, some people in the intensive group that did die, but that just happens as people get older. But as a group, they tended to die less. They were healthier, fewer heart attacks, strokes, and cardiovascular events. And so this study and studies like this really solidify that for us, saying the best data that we have really support a tighter blood pressure control, a more intensive, rigorous blood pressure control. And if you take dozens of studies, totaling about 100,000 people that have been studied, you can see here on this x-axis, the more reduction you have in the systolic blood pressure, or that top number, the more reduction you have. So if you're starting from a high number, you bring it down more, then your risk reduction, how much you're reducing that risk of having cardiovascular or heart disease events, will be more. So if you have starting with a very high blood pressure, and you can reduce your systolic blood pressure by 20 points on that number, going, let's say, from 160 to 140, from 150 to 130, you will be reducing your risk of almost 40%. You're reducing your risk of having a heart event by about 40%. And that's a massive decrease from getting your blood pressure down from this one intervention. So the preponderance of data, the preponderance of evidence, all of the studies looking at hundreds of thousands of people really support the latest blood pressure guidelines to target, for most people, a blood pressure of less than 130 over 80. And I will tell you that there's a lot of naysayers that came up at various points. Some people said, oh, well, old people shouldn't, maybe we should let people who are older have a higher blood pressure. Well, that's also been studied. And it turns out that they should also target a blood pressure of less than 130 over 80. Some people said, what about people with heart failure, or people with kidney disease, or people with all sorts of different things? They tried to kind of say, like, well, maybe there's a carve out. Maybe we, and everyone's looking for an excuse, right? We all want an excuse. My blood pressure could be higher because. Well, the truth is, with very few exceptions, your blood pressure really should be less than 130 over 80. Now, if you're frail, if you have a history of falls, if you're maybe in a nursing home, yeah, it's a different story. So we're not talking about everybody. There are exceptions. But that exception is a rare thing. And for the most part, you really want to try to get a target of a blood pressure that the top number is consistently less than 130, and that bottom number is consistently less than 80. And that will maximally reduce your risk of having bad events, that will actually keep you healthier for longer. Now, the one thing I really want to kind of explain is that how we check our blood pressure is very important. Because if we're just checking it in the wrong way, then it's not accurate. And if we're using a measurement that's not accurate, then we're targeting the wrong thing. So behind this little Family Feud style X is the typical way that we might check blood pressure in the office, which is, you're chit-chatting, you're standing up, your arm is raised. So that's not really going to give you an accurate blood pressure. That can throw off your blood pressure by 10, 20 points easily. And so how do we know what we're treating if we're not checking it correctly? We should be looking more like this patient and this assistant on the right here, or this nurse on the right here, where the patient is sitting comfortably, the feet are flat on the ground, the arm is resting, and that's how we really should be checking the blood pressure. I'm going to harp on this a little bit, and I'll explain why. There are many causes of blood pressure inaccuracy. That includes crossing your legs, the cuff over the clothing. The cuff is too small, the cuff is too large. If you really have to go to the bathroom, you really have to urinate, you're holding it in, that's going to raise your blood pressure. If you're chit-chatting, checking your phone, listening to the radio, watching TV, that's going to change your blood pressure. If your arm is up, if your arm is down, if your back is not supported, all of those things can change your blood pressure drastically. And when I talk about a blood pressure target of less than 130 over 80, I'm specifically talking about a resting blood pressure. And a resting blood pressure has to be followed by a certain protocol. And all of these things will not give us a resting blood pressure. So imagine your last visit to the doctor's office. You're a few minutes late because of traffic, you're kind of anxious, you get called into the office, you walk down the hall, the assistant or the nurse is asking you how your day is going. You sit up on that little table. It's winter time, so you're wearing a sweater. They throw the cup over the sweater. You're holding up your arm like this. Your legs are crossed over. You haven't had a chance to go to the bathroom. Gosh, you're not going to get an accurate blood pressure. So when they tell you that your blood pressure is 150, well, I don't know. Should we treat that 150, or is your blood pressure actually 120 and it's perfect? And so it's so important that we actually know what your true resting blood pressure is. And these are some of the things, again, to reiterate, what are so important. You got to go to the bathroom. Use the correct cuff size, not too small, not too big. It's like Goldilocks. Don't have a conversation. Don't look at your phone. I tell my patients, this is your 5 minutes of meditation and rest and relaxation for the day. Just close your eyes and relax. I put a timer on for 5 minutes and I have them, and then we check the blood pressure. You have to sit in a chair. I have all of my patients come off of that exam table, sit in a regular chair and rest their arm on either the side of the chair or on a table next to them. And I give them a few minutes to relax, and then I check their blood pressure. And that's the way to get a proper office blood pressure. Now, the problem with that is that many offices are really busy. And so what's one solution to that? We can do home blood pressure monitoring. And many of you may have home blood pressure monitors, and cuffs that you check your blood pressure at home. Now, I suggest that you don't check it when you're, 18 times a day and make yourself a little crazy, because that's not good for anyone either. So you really want to check it by a certain protocol. You want to check it at certain times of day. But the benefits here is that it obviates or gets rid of some of the issues with time constraints in the office with the doctor. You can identify what's called white coat high blood pressure, which is when it's higher in the office than at home. And I tell my patients, I say, look, 99% of your life, thankfully, is not in the office with me. So I care much more about your home blood pressure reading than I do the office. At the same time, some people have masked hypertension, where it actually looks very good in the office, but it's higher at home. And that's a problem because 99% of your life is at home. And if your blood pressure is high at home, then that's a problem. We can sometimes do a blood pressure for 24 hours. We actually give you a cuff and you go home with it. It can give you the whole cycle, a full 24 hours of blood pressure control or blood pressure measurements. And I'll show you what that looks like. And we can actually allow for, we can do more telehealth visits, right? A lot of times I'm seeing patients just to see how their blood pressure is doing. But if they check their blood pressure at home, then you don't have to schlep into the office to see me. Now, there are two options for home blood pressure. One, you get a cuff, you check it yourself, and you keep a protocol, and you write down the log, and you keep an eye on it. The other is 24-hour ambulatory blood pressure monitoring. Not every doctor's office is equipped for that. Some cardiologist office, some internists, primary care doctors, and many nephrologists and kidney specialists have this available. For the 24-hour blood pressure monitor, which we'll talk about in a second, it's a little more complicated, but it does give us a lot of information. Now, for the home blood pressure monitoring, you want to keep a log that looks something like this. In the morning, you want to take 2 blood pressure readings, 1 or 2 minutes apart. In the evening, you want to take 2 blood pressure readings, 1 to 2 minutes apart, and then you want to record. And typically, I want to get about a week's worth of this. It's a lot to ask, right? 4 blood pressure measurements a day. So I don't need it every day. I don't need it for 3 months. If I get 5 to 7 days of this, that gives us about 20, 25 blood pressure readings, and it gives us a good sense of what's going on. The important thing is that we do it in a very strict, regimented way. In the morning, check it early, first thing in the morning before you start your day, before you take your blood pressure medications. Because after you take your blood pressure medications, your blood pressure will come down. But I care that your blood pressure is low the whole day, all the way through to the next morning. So I want to know what the blood pressure is before your medications in the morning. Check it twice after 5 minutes. So it's about a 7-minute protocol, 5 minutes of rest, just like I talked about. Check the blood pressure once, wait 30 to 60 seconds, check it again, write it down, move on with your day. In the evening, I typically tell patients and people to check it just before dinner, sit for a few minutes, and then write it down. Obviously, if you're cooking dinner and you have a couple of kids at home and you're being driven crazy, please don't check the blood pressure then because it's not going to be helpful. It may be high, and that's okay. But find a time where you can sit and relax and get a good solid reading. Get 20 to 25 readings over the course of the week, and then we can really get a good sense of how your blood pressure control is. First, the key, though, is that you use a machine that is validated. And people don't realize this. There's thousands of blood pressure machines on the market. Just because it's on the market doesn't mean it's accurate. I recommend you all go to this website, validatebp.org. It's an independent organization, not for profit, that validates blood pressure cuffs and machines and says that we are confident that these are accurate machines. Because if you go home, if you go to the store or you go to Amazon and you purchase a cuff that's never been validated, it could be off by 5, 10, 20 millimeters of mercury. So if you make it not give you the measurements you want. So you really want to get a validated blood pressure. And I suggest you look at this website, validatebp.org. It's very helpful. Now, for those people that don't want to check their blood pressure at home, or if we're concerned about variation throughout the day, we can do this 24-hour ambulatory blood pressure monitoring. And what does that look like? You come into the office, we fit you with a cuff. It's connected to a tube to a small device. Looks like the size of a pager, if anyone remembers what those look like. And you basically check your blood pressure every 30 minutes for a 24-hour period, including while you're sleeping. It gives us very pretty graphs that look like this. And it gives us a tremendous amount of information. How is your blood pressure while you're sleeping? How is it at various times of the day? People keep a log also of their activities that they do during this day. And we can really target sometimes for complex high blood pressure or when it's labile, very up and down. We can get a better sense of how to get the right medications and whether or not you need medications or what types of medications might be appropriate for you. Again, it's a little cumbersome, but it gives us a lot of information. I use this tool very often in my practice. And I'll tell you, sometimes it allows me to avoid giving more medications to patients that I see because the blood pressure in the office is often high, 140, 150, but it may be 125 with the 24-hour blood pressure machine. And I can be very confident that they have a little bit of a white coat effect when they come to see me, despite the fact that I don't wear a white coat. But at home, it's good. And that's really what's important. Okay, so we've gone through a little bit of the background. Hopefully you all appreciate why high blood pressure is important. Hopefully you can agree with me that we really want to get good, tight control and that you really appreciate the importance of proper measurements. And don't feel it may be a little awkward, but don't be shy about getting it checked correctly in the doctor's office because we if any of you have diabetes or thyroid disease or any other thing, and we check your blood test to monitor your diabetes. Imagine you check your glucose, your sugar levels to monitor your diabetes, and I told you it could be off by as many as 20, 30, 40, or 50 points. What are you supposed to do with that? High blood pressure, it's so easy to measure, but it's also so easy to get it wrong, and it's so important. So really, kind of push them to get it right. Now you have high blood pressure. Well, what do we do about it? So at Northwell, we've developed a management algorithm. This algorithm that I'm going to show you, this is really designed to help the doctors, but I really want to kind of pull back the curtain, show you what we're doing, so you understand and you can appreciate where we're coming from when we talk about different medications that we think might be appropriate or other things that we think might be appropriate. I'm going to walk you through this, and we'll take it step by step. So the first thing is for people that have diagnosed high blood pressure, and they're close to goal. Your blood pressure is 135, it's 138, maybe even 142. So you're not so high. You're not at 160, but you're not quite where you want to be. You're not less than 130. So the first thing we would start with is lifestyle therapy. And I would tell you that lifestyle therapy is going to be part and parcel of everything, no matter how high your blood pressure is. The only difference is, can we get away with trying lifestyle modifications alone, or do you need a medication in conjunction with it from the outset? If you see me in the office and your blood pressure is 160, 170, I'm going to need to start you on medications and lifestyle modification. If it's kind of borderline, if it's a little bit high, we could talk about lifestyle modifications first. And the reason why lifestyle modifications are so important is you can see different modifications here. And you can see the drop in blood pressure of your systolic blood pressure with different lifestyle modifications. And this is the equivalent of 1 and maybe even 2 blood pressure pills. So you make some changes, and that's the equivalent of taking a pill. Now, some people might say, I'll take a pill. But the pills have side effects, and who wants to take a pill when you can? And this is actually a much healthier way to go about getting your blood pressure under control. Losing weight, going on the DASH diet. So it's a diet that's proven to be heart healthy, to lower your blood pressure. Sodium reduction. This is a big, big thing. We have a big problem, right? It's high salt diet. We all eat too much salt, and that's going to drive blood pressure. That's really a big problem. Interestingly enough, people don't realize this. Increasing your potassium intake is actually very healthy. Potassium is a salt, just like sodium is a salt. We talk about salt generically because it's sodium, that's the most common, but there's sodium salts and there's potassium salts. If anyone remembers their periodic table of the elements from 8th grade chemistry, it's in the same column, potassium and sodium. They're in the same column. They're very similar, but just different enough where one is good and one is not so good. Now, it's really about the balance. You want to have a high potassium diet and a low sodium diet. Turns out, all of the healthy stuff contained a lot of potassium. Fruits, vegetables, beans, lentils, legumes, stuff from the ground, natural foods contain a lot of potassium. Processed foods, breads, packaged foods, things like that contain a lot of sodium. And so you really want to kind of just rebalance a little bit to get that blood pressure down. Exercise, dynamic and isometric resistance, alcohol reduction. Alcohol is a major driver of high blood pressure. You really want to kind of keep an eye out for that. And also, one thing I always talk to people about is understanding what other medications are you taking, and not just prescription medications, over-the-counter stuff, right? The biggest call, and here, you can see there's a laundry list of stuff. But notably here, up to 20% of people with high blood pressure are taking medications that can raise their blood pressure, and sometimes they don't even realize it. Sometimes the biggest culprit is this one, non-steroidal anti-inflammatory drugs, sometimes known as NSAIDs, that include Advil, Motrin, Aleve, ibuprofen, naproxen. That can raise your blood pressure. Now, before you get too worried, if you've got occasional pain in your knee, you bumped your elbow, Advil for a couple of days or Advil every couple of weeks for a headache, no problem. Don't worry. It's totally fine. But some people take it regularly. I saw somebody that used to take Advil PM to help them sleep at night. Advil PM is just Advil and Benadryl, but they really wanted just the Benadryl. And then I dropped the Advil, told them just take the Benadryl, and their blood pressure came down really nicely. So something to always think about. There are a lot of medications that can raise your blood pressure. And so be honest and open with your doctors when you talk about this. Don't just tell them about your prescription drugs. Tell them about any over-the-counter, herbals, supplements. People always say, can I take an herbal or a supplement? And oftentimes, my only hesitation is just tell me what you're taking, because I want to check to make sure it's safe. If there's a concern, if it's driving high blood pressure, if it's driving problems, let's have that conversation. But it's really important that we have an open and honest dialogue about it. So once we go beyond lifestyle modifications, and once we talk about other medications that you may be on or interfering medications, over-the-counters and herbals, we're talking about antihypertensives, which are commonly known as blood pressure medications. So which one? So in our algorithm at Northwell, this really follows the guidelines. The first question we want to know, do you have certain medical conditions that would make it more important that you be on specific blood pressure medications? And those include diabetes, heart failure, or kidney disease. And you see up here, if you have any of those, you want to go down a different pathway than if you don't. If you have any of those, you want to take one of two different classes of medications. And this is important to understand. There are many there's dozens of blood pressure medications, but they fall into different classes or different versions of the same one. It's basically, you've got like 5 different versions of the same blood pressure medication, just different slight differences, and probably from different pharmaceutical or drug companies, but basically the same, right? So, in this here you've got a class of drugs called ACE inhibitors and ARBs, which stand for, it's a bit of a mouthful, but angiotensin receptor blockers. And those are really important for people with heart failure and kidney disease, diabetes. They're good for your kidneys and your heart, and they also lower your blood pressure. So we really prefer that people take those if they've got one of those medical conditions. But if you don't, let's say you're relatively healthy, maybe you've got just a little bit of high blood pressure, a little bit of high cholesterol, then you've got 3 options, and really it's really up to your preference and working with your doctor. There's 3 classes of blood pressure medications you can choose from. One is a CCB, otherwise known as calcium channel blockers. One is a thiazide or diuretic. We commonly refer to those as water pills. In reality, they're more like salt pills. They get rid of excess salt, which drives down your blood pressure. And then the last one is that same ACE inhibitor or angiotensin receptor blocker. So you start with one, may have to add on a second or a third as we go. I will call out a special consideration if you're pregnant or trying to conceive. You want to be careful because there are certain medications you want to avoid or be. So you have to. So that's a kind of a special population to be considered. And then you'll notice down here, this is really important, and we're not very good at this, but we want to follow up every 2 to 4, no more than 6 weeks. Rapidly titrate those medications to get you down, because we know that time is important here. The quicker we get your blood pressure down, the quicker we get you to goal blood pressure, less than 130/80, the quicker that we are reducing your risk of having heart attacks and strokes and bad events happening. So we really want to do this quickly. We don't want to say, here's a new medication, come back and see me in 6 months. You want to get this done quickly. Within a month or 2, you really want to get down to that target goal. Now, I talked a little bit about the different classes of medications. I spoke about 3 primary classes. Or there's 2 in this group, but I'll go one by one. But I did not talk about this last one. I'm going to explain why. So the first one is the calcium channel blockers. The most common is amlodipine or Norvasc. It's a great blood pressure medication. Works very well for lots of people. And sometimes there are some side effects. Some people get a little bit of swelling of their ankles. It's not dangerous, but it could be a little unsightly, or people can be bothered by it. But it's pretty well tolerated. Thiazide diuretics. These, again, the most common is hydrochlorothiazide, and there are a couple of others as well that are on the market and available for, and it's also a great blood pressure medication. You need to monitor some people's electrolytes when you start it. So we get a blood test about 2 weeks after, because it is causing you to lose electrolytes. You want to keep an eye on the electrolytes in the blood test. Most people do just fine with that. There are, and this works very well for people who are very salt sensitive. And so that can be a very good blood pressure medication for many people. This last group, there's actually 2 different classes, and I lump them together because it's one or the other. You can't take both. One is called ACE inhibitors, and one is called angiotensin receptor blockers. They're almost like twins, but like a slight difference. So they act in a very similar way, and so taking both can cause big side effects. We avoid taking both. Pick one. My preference is angiotensin receptor blockers, or ARBs, because they work just as well with fewer side effects. But if you're on an ACE inhibitor and you've been on it for 20 years, no side effects, by all means, stay on it. So these are some of there's a whole long list. The lisinopril is a very common one. Ramipril, enalapril, these are very common. These are the ACE inhibitors. They all end in a pril. The ARTANs, like losartan, otherwise known as Cozar, or telmisartan, or valsartan, those are the ARBs. I am a big fan of those. You have to keep an eye on electrolytes, similar to the thiazides, but they tend to have very few side effects, very well tolerated. So they're great medications. Now, this last group, the beta blockers, a little red, exclamation point there. And you'll notice, I'm going to go back, it's nowhere to be found in the algorithm. And the reason is, for many years, these were thought to be excellent blood pressure medications. And in fact, they will lower your blood pressure, but they won't give you the risk reduction that you deserve. These other three classes, these other three groups, the calcium channel blockers, the thiazide diuretics, and the ACE inhibitors and ARBs, they will lower your blood pressure and reduce your risk of heart attacks and strokes. But relative to these three, the beta blockers are a little different. They may lower your blood pressure, but relative to the other medications, you'll have a higher risk of heart failure. You'll have a higher risk of stroke. And they're riddled with side effects. There are specific indications and reasons why someone should be on a beta blocker. You have arrhythmias, like atrial fibrillation. You have a history of heart failure. You had a recent heart attack, or you have angina or chest pains. Those are good reasons to be on a beta blocker because they'll help your blood pressure and they'll also help the other condition that we're trying to target. But if the only reason you're on a beta blocker, like labetalol, like metoprolol, like atenolol, if the only reason is for high blood pressure, it's probably time to move on. And it may be controlling your blood pressure, but it's not giving you the risk reduction. And as I said at the outset of this talk, I don't care about a number, right? I'm targeting the number because the number is associated with the risk reduction. But if the number and the risk reduction are not associated, if I'm not getting the risk reduction that I really care about, then why am I giving you a pill? So we really need to think about that. And it doesn't mean there's no role for beta blockers, but it's not the first, second, third, or even this stage, fourth line blood pressure medication. There are better blood pressure medications out there. At the bottom right, you'll see some others. These are rarely used except in extremely rare situations. If you're on one of these and if you're on one of those at the bottom, like doxazosin or Cardura, like guanfacine or clonidine, and you've never tried a calcium channel blocker or a thiazide or an ACE inhibitor or an ARB, you probably should try one of those first. That's really the way I'm going to leave it at that. All right, so what do we know so far? For blood pressure, generally lower is better. Proper technique and home monitoring is really crucial. Targeting the blood pressure, you do have to weigh the risks, benefits, and values, right? It's possible you'll have terrible side effects of blood pressure medications when the blood pressure gets down to 125. And when it's at 135, you just have a better quality of life. That could happen. It's rare, but it could happen. And if that happens to you, then you have to balance that quality of life with the risks. And it's okay. That's okay. I would accept it. I would understand that. But if you can tolerate the medications, and and not just the medications, the lifestyle modifications as well, we really should target a lower blood pressure. As I mentioned, diet and lifestyle modifications are key. And then the first, second, and third line medications are ACE inhibitor or angiotensin receptor blocker, calcium channel blocker, and thiazide diuretics. Beta blockers are only in specific cases. Now, what happens if you're on three medications? What happens if you're on your calcium channel blocker? You're taking amlodipine, a diuretic like hydrochlorothiazide, an angiotensin receptor blocker like losartan or Cozar. You're on three, and the blood pressure is still high. You may have something called resistant high blood pressure. Now, at that point, there's a few options, and we're not going to have time to delve too deeply into this. There's a fourth line medication. My fourth line blood pressure medication is a medication it's an oldie, but it's a real good one. It's called spironolactone or aldactone. It's an excellent blood pressure medication. You have to keep an eye on the electrolytes as well, like the sodium, potassium, things like that in the blood work. But it's a very well tolerated blood pressure medication, and it's heart healthy, it's kidney healthy, it's a great blood pressure medication. You may also benefit from looking for other causes of high blood pressure. 80% of people with high blood pressure have what we call run-of-the-mill high blood pressure. It's part of your diet, lifestyle, aging, things like that. 10 or 20% of people will have a specific, modifiable, identifiable cause of high blood pressure. And in those cases, it may be worthwhile doing some investigation. And finally, there's always hypertension specialists available to help in complicated cases where we really can't get the blood pressure down. So which medications should I use? And I'm going to kind of give you like the way I do it. But again, I always tell people a few things. One, there's dozens of blood pressure medications, so we can find the right ones for you. Blood pressure medications should be cheap. You may have other expensive medications, but blood pressure medications should be cheap. So if for whatever reason your insurance doesn't cover one, we'll find another. I love trying to do combination therapies and combination pills. It's one pill with 2 or 3 medications in it. Makes life a lot easier. So for angiotensin receptor blockers or ACE inhibitors, telmisartan is my personal preference, but olmesartan and irbesartan are also very good. They're long acting, work really well. That said, if you're on losartan, it's not on my list here, and it's working well for you, stay on it. No reason to change. Diuretics, hydrochlorothiazide is the initial go-to. It's not the most potent, but it'll work for most people. If you still need a little extra oomph, there are others like chlorthalidone. Calcium channel blocker, amlodipine is my go-to. It lasts the whole day, so it's a nice long duration of action. Some people do get constipation or leg swelling, especially once you get up to about 10 milligrams on the pill. So sometimes staying with the 5 milligram dose is enough to kind of get rid of those side effects. Also, interestingly enough, if you combine an amlodipine with an angiotensin receptor blocker like telmisartan, it actually gets rid of some of that swelling. So it's kind of a nice little nifty little trick. If for the fourth line, as I mentioned, spironolactone. If spironolactone is not tolerated for whatever reason, there is another one called eplerenone, which is available as well. After that, it gets a little bit tricky. There's beta blockers, there are other types of medications, but we got to want to be thoughtful on the next line after you go through those four. So I'm going to wrap up. If you find yourself taking a labetalol 300 milligrams 2 times a day, BID is twice a day, hydralazine 50 milligrams 3 times a day, TID, metoprolol, BID, 25 milligrams BID, that's 7 pills in a day, and your blood pressure is still high, you may want to talk to your doctor about a combo pill of a telmisartan amlodipine and a hydrochlorothiazide. I'll give you 2 or 3 pills a day, and you'll probably get your blood pressure under better control. You'll probably feel better, and it'll certainly reduce your risk of having heart events and early death and other complications. So to summarize, cardiovascular disease is a leading cause of mortality and morbidity. Its risk factors, especially uncontrolled blood pressure, should be really aggressively managed. We want to get the blood pressure under 130/80. Check the blood pressure properly. Focus on diet and lifestyle modifications. Evaluate common causes of high blood pressure, including salt, physical activity, other meds. Sleep. I forgot to talk about sleep. It's really important. You need to get sleep. Use appropriate first, second, and third line medications. And avoid inertia. Don't go on a medication for 6 months and come back to the doctor. And the last thing I'm going to point out is, as much as I really appreciate this this picture that that talked about today's talk, at this point, everyone on this call should recognize that we should not check the blood pressure that way. Arm resting like that, it's not the way we're going to do it anymore. And with that, I'll stop and open up for conversation.
That was great. I have to say, we're a little embarrassed almost that we chose that photograph to go in there. It's a good point. We were not emphasizing optimal blood pressure measurement. You're right. Actually,
but it's okay. It's a teaching point, so that's fine.
That's why we put it in there. Exactly. It's literally what I wrote down 3 important teaching points from your talk that I think were so key, and I'm glad you pointed it out. And that literally was number 1, that we need to have an accurate blood pressure, that if we're not treating an accurate blood pressure to begin with, then either you're going to start to get lightheaded because we overtreated you, or your blood pressure will remain high. We have to have accurate data, individualizing to the patient. So we choose medicines, as you said, really dependent on, do you also have diabetes? Do you have heart disease, heart failure, et cetera? So we really choose therapies based on, the entire sort of disease state of that person. And then the third one is, and I tell my patients this, whatever we're dealing with, whether it's cholesterol or blood pressure, whatever, this is actually a process of trial and error. We are going to find something that works for you, but it may not be day one. We might try something and you either don't feel great on it, or it doesn't actually work enough and we have to try something else, or we have to add on. So just sort of be ready for that process and working together with your doc to find something at the end of the day that you'll feel well on and your blood pressures will be under control for. So really, really important teaching points. And I'm just going to ask you a few questions that, a lot of my patients ask me, and I think they're really good questions. So I'd like to hear your perspective on them as well. So lifestyle, you talked a little bit about that. Do you find that it is effective in patients and potentially in some, avoiding medications?
It's a great question. And I'll tell you, it definitely helps. I tell people, obviously, all of those lifestyle recommendations are healthy independent of the blood pressure component, right? So if you're exercising and the blood pressure doesn't come down, because it doesn't for everybody, I wouldn't become despondent because it's still good for you. It's still healthy, even if the blood pressure is not coming down. That said, I do find, when I see people actually take the time and put in the effort to try to eat a little bit better or to try to exercise more, even lose some weight, I definitely see improvements in blood pressure. In the most extreme examples, I do have some patients that are like this doesn't happen often, but I do have some patients that get very nervous when they find out they have high blood pressure, and they take it very seriously. I've had patients that went from like barbecue daily to vegan, like literally completely overhauling their lifestyle, exercising daily, and went from 2 blood pressure medications to 0. It doesn't happen often for a whole host of reasons. First of all, it's hard to get down to 0, but also it's hard to sustain a lifestyle that's that extreme. And I try to find compromises with people that I speak with and the patients. I say, you also have to find that balance, right? I tell people, like I use this example all the time. If you love pizza, pizza is loaded with salt, right? But if you love pizza and you have pizza 5 times a week, who am I to tell you never to have pizza again because it's full of salt? But let's try to find a way to kind of rebalance a little bit. Maybe a little bit of salad with that. Maybe not 5 days a week, maybe 3 days a week. Maybe walk to the pizza store, like things like that. And that definitely helps bring the blood pressure down. Sometimes it's enough to get you off of 1 or more medications if you really are invested in it, if you really put in the time and the effort and take it seriously and consistently. Consistency is really important. But I definitely do see drops in blood pressure and sometimes enough to get off of probably 1. If you're on multiple, is probably the most realistic. But everyone is a bit different.
Exactly. And in some cases, I think they can potentially even avoid. You showed the 130s, maybe 142, that if you do these things, you might not even require the medication.
Yeah, 100%.
Yeah. And you saw this sort of cumulative thing. And that's what happens, I think, with our patients too. Like once they learn their cholesterol is high or their blood pressure is high, they start a medication, but they also start exercising more and they also start eating better and they also start doing other things. So like you're really seeing how each of them is additive over time, which is really, really helpful. And for those who are listening, please go right ahead and type in any questions you have for Dr. Hirsch. I'll keep going in the meantime. Another question patients do ask about is whether or not these medications are going to be needed essentially for the rest of their lives. And they're sometimes concerned about this, but what do you usually tell your patients?
I hate to be the bearer of bad news. Unfortunately, for most people, once they're diagnosed with high blood pressure, it's hard to reverse. And for many people, it ends up being it ends up being a lifetime of being on a medication for their blood pressure. That's the reality of it. And I think, as we said earlier, especially if the blood pressure is borderline or a little bit high, there are ways to come off of it, right? You can do some lifestyle modifications and try to really get the blood pressure down through some diet and exercise. The DASH diet is amazing for this, right? Stuff like that. And that can certainly help. But the reality is that, when people develop high blood pressure, whether it's in your 40s, or more likely in the 50s or 60s, it's not something, most of the time, it's not something that happened overnight. It's a lifetime of cumulative events that kind of brought you to having high blood pressure. And it's hard to reverse 50 years. And so, more often than not, people are stuck on this blood pressure medication. And the good news is, I think to your point earlier, it does take some trial and error, but we can find the right medications that work for you and don't have a lot of side effects. And I think that's, and I'm a very big proponent of, once a day pills, combination pills. Like you literally wake up, you pop a pill, and like that could 1 pill a day could be it. And that could be controlling your blood pressure with minimal side effects.
Exactly. I think that it's interesting. Sometimes genetics plays a part. So, one of our dietitians who's amazing, Sarah Miller, she sort of explains to patients because they ask about whether or not diet will fix their cholesterol in certain cases. And some of our patients have a really strong genetic reason for it, right? In which case, she said, the way she explains it is if lifestyle didn't actually cause this cholesterol issue, then it's like unlikely that lifestyle by itself is going to fix it. So same thing with the blood pressure. Sometimes you can. Sometimes if you get everything under control with lifestyle, your blood pressure is good, then no, you don't need the medication, lifetime. On the other side of that, I always tell my patients that, I think, the concern of taking a pill for the rest of your life is another thing to think about. Like, why does that bother me so much? Because the way I view it is if you could take a single pill every day and then know that you're not going to have a heart attack or a stroke and you're going to have quality of life for the rest of it, sounds like a really good deal, actually.
Yeah.
So so I think getting over the fact that, I'm taking a pill for the rest of my life is one thing, but it doesn't necessarily mean that it has to be that case, the way if you actually do lifestyle in some cases.
Absolutely.
Yeah. How about time of day in terms of meds? And you showed the ambulatory blood pressure monitor and people monitoring. What is your suggestion for timing of pills in general?
So there was a thought over the last 5, 10 years that, this concept of, it's called chronotherapy, which is timing the therapies to specific times of day to maximally reduce your risk. And the data haven't, in the studies that have come out more recently, haven't really borne that out. I really think that it's incumbent upon us as the prescribers, as the physicians, to really try to work with our patients to figure out what works best for them. We're very, taking a medication every single day for the rest of your life, even for 5 days for antibiotics, by the way, is really hard. And life gets in the way. And so I always say, whatever the time of day that you are most likely to take it consistently, that's fine by me, because that's the most important, right? If I try to get fancy and say, I want you to take this one at 7 a.m. and this one at 4 p.m., then it becomes a mess. And that's why the medications that are inherently twice a day, like a metoprolol that's twice a day, or a hydralazine that's 3 times a day, it's a terrible choice because honestly, I wouldn't do it. And so how can I ask my patients to do it?
100% agree. I will not take that 3 times a day medicine accurately, unfortunately. But yeah, some of the techniques for patients to make sure they're getting their medicine is really making it easy, even if they don't necessarily like the idea, but a pill box, it's really easy, sort of put it somewhere next to your coffee machine in the morning or anywhere that you'll remember. And then it becomes easy. If you put the pills in, let's say on the weekend and you have them for the week and it's somewhere that's visible, that actually takes out, the challenge to it. And then you can get it done. But I 100% agree that these medications are only effective if we actually take them. So
Yes.
make it easy for yourself, work with your doctor, say, look, there's no way I'm taking that 3 times a day. Maybe we can find something else that would be a better plan. So agreed. Great. Any final thoughts for our audience? This has been really, really informative.
I guess I would just say, I think, lifestyle modifications are crucial, right? This is, I think that's absolutely important. Even if your blood pressure is well controlled on medications. Don't give up on that. Like I think it's really it's so important. All of these things that we do, whether it's cholesterol management, whether it's diabetes management, whether it's blood pressure management, it's all trying to really give you the longest and healthiest life. Like I joke with patients, I'm like, how like when they come and see me, I say, okay, how many years more do you want to live? Let's aim for that. But they have to be healthy years, right? And so everything we do here is trying to do that, which is why I don't believe in putting people on medications that might fix the number but not actually help you. And so it's really getting you on the right medicines, but not ignoring the importance of salt reduction, the importance of daily exercise or daily physical activity of some degree. You want to kind of keep your body moving, finding that balance and making it much as easy as possible, right? I think the point about the pill boxes is really instructive. Like everything's got to be habit forming. And so, if you have, even talking about like food and if you have a box of cookies in your house and it's 10 o'clock at night, you're going to eat the cookies. But if you don't have cookies in your house, you might be hungry, but you don't have any cookies. You only have carrots. You're going to eat the carrots because you're hungry. So you want to make it as accessible and as easy as it is to do the right thing and to kind of create those habits that are sustainable. And then the other thing is I say, I talk to my patients about a partnership. In working on blood pressure. It is a lifelong thing, right? Once you have high blood pressure, most people will have it forever. So it is a partnership. And there's compromises, There are times when blood pressure might be a little worse because it's the holiday season and you really want to enjoy the time with your family. And and it's about finding that balance in life. It's about having an open, honest dialogue with your doctor about the medications, how they're working, about which medications are acceptable, about what blood pressure is acceptable. And then also, I would say, last thing I would say is, as part of that dialogue with your physicians and with your medical providers, is push back if they're not checking your blood pressure correctly. Don't be shy.
Just like you did with the image on the screen. Absolutely. Tell them I actually learned quite a bit, and this is how we'll have to check my blood pressure. Great, great advice. Excellent. So thank you so much for joining us, Dr. Hirsch. You're a great expert on this, and really informative information. And we'll be sharing more exciting topics coming up in the next month or two. So thank you for joining us, and have a great night.
Thank you so much. Good night.
Take care.